For joining us on Facebook Live today. We're here to discuss ACL injuries. I'm Doug Boylan. I'm an orthopedic surgeon who has been here in Doylestown in Bucks County for the past 20 years. I'm a member of Bucks County Orthopedic Specialists. We are a team of 11 physicians, 6 physician assistants, as well as an outstanding staff and administrative team here to take care of your orthopedic needs. We care for all orthopedic issues, including sports injuries, knee and shoulder problems. We also take care of joint replacements, hand issues, spine problems, pain management issues, pediatric issues, foot and ankle, concussions, and fractures. So on to some ACL injury issues. What I'd like to do is I'd like to start this by answering a few of the common questions and then proceeding and being able to be here to answer some of your questions as well. First of all, one of the most common questions is, what is an ACL? The ACL is an anterior cruciate ligament. It's a broad ligament that's inside the knee. It helps to support and give stability to the knee. It prevents the shin bone from sliding too far forward on the thigh bone, and also helps with rotational stability of the knee, so that when there's a torque or a twist to the knee, it gives us some stability. Second question that's common is, how does one injure their ACL? So ACL injuries are most commonly thought of as sports injuries. Some of the more common sports that are involved with ACL injuries are injuries that cause you to want to decelerate, or kind of running and stopping, twisting, turning, and pivoting, also jumping. So injuries related to soccer, basketball, lacrosse, football, skiing, cheerleading, as well as gymnastics. Those are probably the more common sports that give people issues with ACL tears. So although it's commonly thought of as just a sports injury, but as long as it was a sports injury, it's commonly an injury that happens with everyday activity. So people who are working on uneven ground, whether at work or at home, can sustain an ACL tear. Also, just keeping your foot planted, twisting and pivoting can cause an ACL tear as well. So ACL tears are not limited to just sports. They are fairly common injuries in other activities as well. Third common question, how do I know if I tore my ACL? So usually the person or patient is active when they tear their ACL. Normally they feel a pop and they have pain. Normally they fall to the ground. They have difficulty getting up and walking and putting weight on it. Within about 24 hours, typically the knee will swell pretty significantly, and the patients will lose motion and range of motion with their knee. Those are the most common symptoms associated with an ACL tear when it occurs. Fourth common question is, how do you treat an ACL injury? So usually at the beginning, we're going to treat an ACL injury with support to the knee, whether it's potentially a knee brace or some crutches. We're going to recommend ice. We're going to recommend some anti-inflammatories. Over the course of 4 weeks, and usually after about a week, we ask patients to start working on range of motion and placing weight on their knee. After approximately 4 weeks, most patients are able to begin walking fairly normally on their knee, even though they've torn their ACL. And that occurs after the swelling has subsided. Next question is how do you, or can I treat my ACL injury non-operatively, which is what we're here to talk about today. And so the ACL itself won't heal itself. It won't mend itself back together. So ACL tears typically only occur with reconstructing the ACL. That doesn't mean that everybody necessarily has to have their ACL reconstructed. Young active people who tear their ACL usually want to get back to their activities and don't want to be limited with the activities that they want to get back to. Typically, those patients are going to opt for ACL reconstruction in order to give their knee stability to get back to doing the things that they want to do. Older active patients may wish to go along and proceed with a treatment consistent with some physical therapy. Physical therapy to help strengthen up the leg, to help get motion back. They also may want to use a brace to see if that helps them to be able to get back to their activities. So between bracing and physical therapy, a trial with older active patients may be certainly appropriate. Some of those patients, though, certainly will find that they're not able to get back to their previous activities after doing something like that. They may opt for ACL reconstruction at that point in time, which is perfectly reasonable. Other patients that are older and active may need to, and do not wish to proceed with ACL reconstruction, may need to modify their activities. So instead of certain activities which require twisting, pivoting, and jumping, they may need to go ahead and get back to just biking, running on a treadmill, and doing some activities which don't require as much ACL stability for the knee. Still, other patients that are fairly sedentary but may still tear their ACL certainly can go ahead and proceed with physical therapy, a knee brace, or something else, which may not require surgery. But still, even some sedentary patients have problems with just regular activities of daily living if they're ACL deficient and they've torn their ACL. So while not everybody needs to have surgery following ACL reconstruction, most patients will get back, will opt for ACL reconstruction in order to get back to our activities that they were performing prior to their injury. So if there's any other questions, I'm happy to answer those now. And I have one from Karen here that says, how long after ACL surgery until I can play contact sports again? So that's a good question. So ACL surgery is, we'll talk a little bit about ACL surgery first. And ACL surgery is typically an outpatient procedure. Usually takes about an hour to an hour and 15 minutes. Patients go home the same day. Typically, they will be limited with how much they're able to bend their knee with weight bearing at the beginning. But in order to get back to playing contact sports, most patients are waiting approximately 8 months to a year. And the reason for that is they have to get their quadriceps and their hamstring strength back, and also to continue working on core strengthening to help try and prevent a second injury after having their ACL reconstructed. Another question here, Michelle Horn asks, how long will I have to wear a brace while playing sports after ACL surgery? And so while the goal is optimally not to have to wear a brace after having your ACL reconstructed, some patients still prefer to wear a brace when they first go back. Some patients, in all honesty, have some difficulty getting back to the same level of activity that they had prior to ACL reconstruction. Sometimes that's more mental than anything else, in the fact that they injured their knee at that activity and it's tough for them to get back. So having an ACL brace when they return to sports is sometimes not a bad thing for patients, to give them a little more confidence when they do return. But the ultimate goal is for patients to be able to return to sports without wearing a brace, and for them to rehab their leg well enough so that the strength is there in order to be able to continue with all activities following ACL reconstruction. Joe asks, is the recovery different in the first 12 weeks compared to having surgery, and is there a different treatment protocol? I think that initially following an ACL injury, for at least the first 4 or 6 weeks, the protocols are very similar. And that's just letting the knee settle down, calm down, let the swelling come out, be able to get your range of motion back, and be able to develop a little bit of some quad strength, whether you're undergoing surgery or not undergoing surgery. If someone's not going to proceed with surgery, then I think obviously physical therapy is very important. I think it's important to help regain motion, but also help to regain not only the quadricep strength, which is very weak, but help to balance that with the hamstrings. The hamstrings also help to prevent translation of the tibia or the shin bone anteriorly on the thigh bone. So the hamstrings help as a restraint, trying to help the ACL. So if you're ACL deficient, you want to make sure the hamstrings and the quadriceps are fairly well balanced. In addition, you want to also do a fair amount of some core and hip strengthening exercises. And that helps to protect the knee in an ACL deficient knee as well. So I think the differences are that leading up to surgery, I would say that the rehab or the activities are similar. After surgery, I think it's a different approach for operative and non-operative treatment. I have a question from Jordan V. Will I require a total joint replacement if I tore my ACL at 16 years of age due to arthritis? So that's a good question. I think that the younger patients tear their ACLs, the more likely it is that they are going to have some issues with their knee later on in life. While ACL reconstruction is supposed to be able to restore knee stability, which it does better than non-operative treatment for ACL tears, the knee still has potentially some damage at the time of that ACL injury. They can injure the meniscus at the time of injury. They can injure the articular cartilage. What leads to arthritis in a knee is the articular cartilage, which is a smooth, shiny surface on the end of our thigh bone, top of our shin bone. When that wears away, that's what arthritis is. The ACL in the knee helps to give stability to try to keep the knee itself from wearing too much and also protect the meniscus. So a knee with an ACL that's working well helps to protect the meniscus, which helps to protect the cartilage, which then helps to prevent arthritis later on in life. So by having an ACL tear at the age of 16, if you have your ACL reconstructed, the hope would be that your knee would remain stable and would also lead to less injury over time. That hopefully would give you a little bit less of a chance of requiring a knee replacement in the future. There's many different issues with patients who end up with knee replacement. Some patients have meniscus tears where a large piece of meniscus had to be removed. There's other post-traumatic issues for patients having arthritis requiring knee replacement as well. And there's a genetic component to people having it. So even if you have your ACL reconstructed, you may be someone who has a genetic predisposition to having a knee replacement in the future. But it is generally thought that your best potential of trying to maintain the structures in your knee is to have a good, stable knee. And usually at a young age, that would include reconstructing a torn ACL. Another question from Alex asks, if I tear my ACL playing sports, can I tear it again? That's another great question that has been studied over time, and more recently, studies come out that patients who have had their ACL torn and have had it reconstructed, there is approximately a 4.5% chance that you will re-tear your ACL again with being back to activity. And there's a 3% chance actually that you'll tear your opposite knee ACL. And those risks of that go up. And what it includes, there's a study that was done that showed that the younger a patient is when they tear their ACL and have it reconstructed, the more likely it is that they may tear their ACL again. And secondly, their activity level, and they tested and looked at what people's activities were after a ACL reconstructed. And it would only make sense that the higher level activities of patients go on to tear their ACL as well. So higher level activity, younger patients have a higher chance of tearing their ACL. It is relatively small in that it's 4.5%, but some patients are just prone to ACL tears in that they're prone to tearing their opposite side even after you reconstruct the same side. So it is possible, but we think that your knee would be more stable by having it reconstructed than not to get back to sports and athletics that you wish to. Another question here by Kathy H. asks, is an MRI always required to diagnose an ACL tear or just an X-ray? And so typically an X-ray is not going to show an ACL tear. Patients who have an injury will often maybe go to the hospital. They may get an X-ray taken there. The X-ray will be negative, but obviously something's wrong with the knee. There can be a small fleck of bone called a Sagoon fracture, which certainly makes us think that someone has an ACL tear on X-ray. It's not very common that we see that, but X-rays are normally negative and don't show anything. MRI is very common. A good physical exam can often diagnose an ACL tear, but if someone's very swollen and has decreased range of motion, then sometimes that's hard. An MRI will confirm the presence of an ACL tear. It will confirm whether or not there's any other injuries to the knee, such as articular cartilage damage or meniscus tears or potentially a stress fracture. MRI is typically performed in order to confirm the diagnosis of an ACL tear. I have another question from Jed. Jed asks, I have a meniscus tear and I've had multiple injections that only seem to work for a couple of months. How long and what frequency can I keep getting injections? So meniscus tears, similar to ACL tears, don't heal themselves usually. The younger you are, you have a better chance of it healing. Patients under the age of 30 have a better blood supply to the meniscus, and that meniscus can potentially heal itself. However, not always. The longer a meniscus continues to give someone trouble, if they don't have much in the way of arthritis, and I'll repeat that, if they don't have much in the way of arthritis and they have a meniscus tear, then typically an arthroscopy may help with their symptoms and take care of the underlying problem that the tear is causing. A cortisone injection doesn't heal a tear. It may help with symptoms and inflammation, but does not heal the tear. So cortisone injection can be given a couple times a year, usually a few months apart. But if the cortisone injection doesn't take care of the meniscus tear after the first injection or two, I doubt that it's going to ultimately solve the problem. Another question here from Brittany asks, if the ACL is not reconstructed, does that lead to long-term problems in the knee later? And I think that's a great question as well. One of the reasons to consider ACL reconstruction is not only to be able to get back to your activities, but it's to protect other things in your knee. So with the ACL being torn or an ACL deficient knee, you have a much higher incidence of injuring other things in your knee. You can tear your meniscus, you can tear or you can damage the articular cartilage. The meniscus, there's two of them in each knee, one on the inside half of your knee and one on the outside half. And they're C-shaped rings that act as shock absorbers. They sit in between the end of your thigh bone and the top of your shin bone, and they help to protect the articular cartilage. Because when that articular cartilage wears away, that's what arthritis is. So a tear of the meniscus is a problem, and if you don't have your ACL reconstructed, you're at a higher chance of tearing that meniscus, which then can lead to further problems. Patients who have their ACL reconstructed can still tear their meniscus, because just like everybody else, if your ACL is intact and you have no problem with your ACL, patients tear their meniscus all the time, and it's actually a fairly common injury and problem. But we do think that there is more protection of the other structures of the knee if your ACL is reconstructed and your knee remains stable after that. I have a question here from John. It says, is ACL surgery done inpatient or outpatient? ACL surgery is done as an outpatient. It is performed arthroscopically through a few small incisions. Like I said, the surgery, as I said earlier, surgery takes about an hour, hour and a half. You go home the same day. Typically, patients may take pain medication at home for just a couple days. I've had some patients not take any pain medication following ACL reconstruction. Some of the differences between ACL reconstruction are what ultimately is used to reconstruct the ACL. A few different options: patellar tendon, which is from someone's own knee, taking a piece of the kneecap, the central portion of the tendon, and a portion of the bone where the tendon attaches is one choice. I prefer to use hamstrings, and we borrow the hamstrings of a knee to reconstruct the ACL. And some physicians may elect to proceed with allograft in certain options. But it is an outpatient. It is an outpatient surgery and not done as an inpatient. I may have answered another question here by Zach, who asks, what type of graft do you use when reconstructing the ACL? And I've always been taught that your tissue is better for reconstructing your ACL than somebody else's. I find that most patients' hamstrings and certainly the patellar tendon is fine as well. Some people will use quadriceps tendon. It's really surgeon preference. But I think any of those make an excellent graft selection. Allograft is used by some as well, certainly is used in patients who have injured more than one ligament or in revision situations. There have been studies to show that allograft in younger individuals have a higher chance of re-tear than if their own tissue is used. However, the chance of re-tear with the use of allograft diminishes after the age of 30. So in younger patients, I definitely think that having an ACL reconstructed with your own tissue is beneficial to having allograft tissue for your ACL reconstruction. As patients get older, it has not shown to make much of a difference. Another question here by Lisa says, do you recommend stem cell therapy or PRP for ACL issues? At this time, stem cell therapy and PRP have not been proven to be beneficial during ACL reconstruction. There have been some studies out there. They've tried to use scaffolding with some stem cells around the ACL. They've been trying to work on repairing the ACL, which was done approximately 40 years ago and shown 40 to 50 years ago and shown not to be very reliable. They are trying to add some of these cells, whether they be stem cells or PRP, and repairing the ACL. So far, those studies have not proven to be more beneficial by using those cells or beneficial to reconstructing the ACL overall. Let's see here. I have another question from Alana. It says, what are some reasons you would choose to repair an ACL versus managing it conservatively? So I think that reconstructing the ACL, I would say, in most patients' cases is probably preferred as opposed to non-operative treatment. I think the studies show that approximately 15% of patients may be what are considered copers. They are able to cope without their ACL being reconstructed and not have any episodes of instability over time. Most other patients, and especially as we talked about earlier, younger active patients, are going to find that their knee's not going to support them as well without their ACL being reconstructed. And so I think the reasons for ACL reconstruction is to provide stability for patients, to be able to get them back doing more higher level activities that they would like to. I think it also helps as a preventative and gives decreased risk of injuring other tissues in the knee, such as the meniscus and the articular cartilage over time. And I think all of those things lead more patients to proceed with ACL reconstruction than others. There's certainly those patients, though, that don't require ACL reconstruction and can be managed non-operatively. Some of those patients that start with non-operative treatment still elect to have ACL surgery, but there are a number of patients that they can go on to do well without surgery. So I think we'd like to wrap it up here for today. Thank you for joining us. I appreciate your questions. We'd just like to say here at Bucks County Orthopedic Specialists that we hope that everybody's staying safe and taking care of themselves at this difficult time. We'd like to let you know that we are taking care of patients through our office. We have, our goal and our utmost concern is for our patients and being able to care for them, but also for our staff and for ourselves and trying to make sure that everybody stays safe and healthy. We currently accept telephone calls and schedule video telehealth appointments, which are scheduled. The telephone number is 215-348-7000. All of our specialists are available for these telehealth appointments. We are seeing urgent and emergent patients in the office as needed, but we're trying to limit those until things become safer for all of us to be back. We at Bucks County Orthopedic Specialists really can't wait to get back to our regular schedules and working again, and we look forward to seeing you in the future. Thanks for joining us.